on coupe la présentation en deux et puis on peut poser des questions en français ou en n'importe quelle langue, il n'y a pas de problème. Mais pour des raisons scientifiques, je pense que ce serait bien de commencer de faire en anglais. Voilà, donc ma présentation, c'est I will start the presentation. This is about the tricuspid regurgitation. We will go through it from the pathophysiology until the treatment. There is a lot to say about the tricuspid because it's a hot topic nowadays. And let's start. So I don't have any disclosure related to this presentation. This is the plan of my presentation. I want to talk first of all about the importance of the problem, tricuspid regurgitation, the tricuspid valve. We need to understand the anatomy of the tricuspid valve because we are going toward a new transcatheter treatment for the tricuspid valve. And if you don't know the anatomy of the tricuspid valve, you cannot perform any repair or replacement of the tricuspid. Next, we'll talk about the pathophysiology and the mechanisms of tricuspid regurgitation, how to image the tricuspid valve, and we'll see the treatment of the tricuspid regurgitation. I will focus on the transcatheter treatment for TR with some examples and the results of recent clinical trials. And we'll conclude after that. So the tricuspid valve was considered as the forgotten valve. If you see the recommendation or anything, the tricuspid valve is always at the end of the document. Also, when you perform an echocardiography, I remember when I was doing my training or you talk to people, the tricuspid valve is secondary. Many practitioners think that if you have a tricuspid problem, this is because of other things. So looking at the tricuspid, yes, sometimes I take a look, but not that much. And then in the report, you will see probably regurgitation, tricuspid regurgitation or severe regurgitation, but nothing else. So this is going to be changing over time. We need to do more for the tricuspid if we want to make from it an interesting valve. And I think we'll go there in 5-10 years. The tricuspid valve will be like the TAVR now, because we have more data about the outcome data of the tricuspid regurgitation. We have a better understanding of the anatomy of the tricuspid valve and tricuspid regurgitation, and we have new strategies to treat the tricuspid valve. If you look at this study published many years ago, this is one of the first studies that looked at the tricuspid regurgitation and its impact on clinical outcome. We can see that patients who had moderate or severe tricuspid regurgitation have much worse prognosis. I mean, less survival compared to those with no tricuspid regurgitation or those with only mild tricuspid regurgitation. And you see the graded relationship between the tricuspid regurgitation and the prognosis. Greater the severity of the TR, less good is the survival. And this is the Kaplan-Meier curve, so this is invariable analysis, but when the authors adjusted for other risk factors and comorbidities, tricuspid regurgitation was independently associated with outcome. It's not because of the right ventricle dysfunction, it's also because the TR itself. So, but despite the increase in mortality, tricuspid regurgitation is still undertreated. In the US, for example, in 2018, the number of moderate or severe tricuspid regurgitation was estimated to more than 1.6 million. Yet only around 8,000 patients were treated. And this is few minority of patients treated, and the remaining patients are left just with medical treatment. This is most likely due to the high operative mortality with surgery. It's around 9-10%. So surgeons don't want to intervene in these patients because, and these are highly selected patients. So we can imagine that the mortality would be greater or higher if we intervene in any patient. And this is why the transcatheter techniques represent an attractive alternative to surgery, because we have some new data now supporting maybe the usefulness of this technique for TR reduction and also at low costs. But this low mortality. As I said, the pathophysiology and anatomy of the tricuspid valve is pivotal, is central in this subject, and we start with from the beginning. And this is the images you will see is from a paper we published the last year in collaboration with Columbia University Medical Center Department of Pathology and also Washington University Medical Center in Seattle. This is a gross anatomy of the tricuspid valve. When you look at the macroscopy, when you do, if you look at the tricuspid valve from anterior perspective, from the RV perspective, the RV is removed, we are looking at the tricuspid valve. The tricuspid valve is looking at you. It's not a horizontal valve. It's almost a vertical valve. It's similar to the mitral. They are looking at you from anterior perspective. So here we have the anterior leaflet. Toward the mitral, we have the septal leaflet, and posteriorly and inferiorly here, we have the posterior leaflet. In 70% of cases, approximately, the tricuspid valve has three leaflets. However, in the other cases, it may have 2 leaflets in around 10% of cases, and also a normal valve can have more than 3 leaflets. So it's only tricuspid in around 70% of cases. And the number of leaflets is important to consider when we are talking about leaflet devices like the MitraClip or Pascal, because this is very important for the strategy. If you look at the valve from posterior perspective, from right atrium perspective, so this is, we cut part of the right atrium on image C here on the bottom right. You can see, so the anterior leaflet here is the one toward the aorta. We cannot see the aorta very well here, but in direction to the superior vena cava. The posterior will be in the opposite side, and the septal leaflet toward the septum and the mitral valve. This is the one at the bottom is the surgical view. The surgeons use this view for tricuspid valve repair. So we have here an open heart, and we can see a normal valve with the 3 leaflets, the posterior, the septal, and anterior leaflets. On the right side, however, we have a normal tricuspid valve with 4 leaflets. In red here, we have an extra leaflet close to the anterior leaflet. This is a 4-leaflet normal tricuspid valve. How it looks like in echocardiography images. On echocardiography images, you have here on the left side bicuspid tricuspid valve. I don't want to use the bicuspid in tricuspid. I use bileaflet, because if you talk about bicuspid, is most likely this is the aortic valve. So it's bileaflet tricuspid valve. You have a septal leaflet, a small but long in the anterior posterior direction, and the lateral leaflet that combine both the location of anterior and posterior leaflet. On the right side, you have a valve with 4 leaflets, septal, anterior, intermediate, and posterior. We don't have an unified or uniform nomenclature for these leaflets. This is a new field. We are trying to characterize them, but one of the nomination is intermediate leaflet. Or if you have A1, A2, for example, as anterior first and anterior second. Now, if we look at the papillary muscles, there is typically 3, but the number is variable. The largest papillary muscle is the anterior one. You see here white asterisk here. It provides support to the anterior leaflet and secondary to the posterior leaflet. If you see the anterior papillary muscle, the large one, that means you are looking to somehow to the anterior leaflet. So it's important when you recognize this on echocardiography, you know this is the anterior leaflet you are looking at. To the posterior leaflet here with the three, you can have 2 or 3 papillary muscles, and they can provide support to the both posterior and septal leaflet. And you can have accessory papillary muscles, especially for the septal leaflet. If you look at the septal leaflet on the right side, you may have small papillary muscles, and you may have direct insertion on the septum, and this have an impact on the pathophysiology, because when you have any kind of problem causing pulmonary hypertension and dilatation of the right ventricle, the septum shift to the left side, and then taking the septal leaflet with it, and it can cause restriction of the movement of the septal leaflet and then regurgitation. And these patients are difficult to treat with any device because the septal leaflet can be short and restricted, and even if you put annular device or any kind of edge-to-edge repair, it will be difficult. So this is very important to recognize when you are doing an echocardiography, especially transesophageal echocardiography. Last thing here for this view on the left side, you can see the moderator band, which can be attached to the papillary muscles or to the free wall, to the right ventricle. Very importantly, the pulmonic valve here, pulmonic valve, is completely separated from the tricuspid. There is no direct contact between the two. And this is very important and interesting for the tricuspid valve, because if you consider transcatheter valve replacement, there is no risk of obstruction here close to the pulmonic valve. This is different than the mitral side, where many times you can cause obstruction of the LVOT, LVO tract flow, if you put transcatheter mitral valve, which is quite big and can cause a problem next to the aortic valve. Tricuspid annulus is one of the structures that is most important to look at, but it's a D shape. You see a D-shaped structure. You have the line here of the D letter on the left side toward the septum, and you have irregular edges toward the anterior aspect and posterior aspect. And the dilatation of the tricuspid annulus occurs here on the anterolateral and posterolateral aspect. Of course, the septum cannot dilate towards the septum. An important structure surrounding the posterior aspect of the tricuspid annulus is the coronary sinus here with the blue arrow. You can see if you are looking at if you are seeing the coronary sinus on the echocardiography, that means you are looking at the posterior aspect of the valve close to the commissure between the posterior and the septal aspect.
Tu m'écoutes, Dahou?
Oui, oui.
Ciao, essaye d'utiliser la souris pour qu'on voit.
Ah, ok, parfait.
Si tu peux utiliser ta souris.
Ah, je l'ai utilisé, mais je pense que c'était sur le mauvais écran.
Là, on voit la souris. Bouge la souris, chauffe.
I think it was on the other side, so this is why.
Voilà, là, on voit une petite souris. Voilà, très bien.
Ah, ok. Désolé, parce que depuis le début, je pouvais cliquer sur le écran. Donc, ici, en fait, here, the D shape of the tricuspid annulus, and here you have the septum, septal leaflet, anterior leaflet, and posterior leaflet. You have the coronary sinus here. As I said, the tricuspid annulus is D shape or oval sometimes, and the dilatation occurs from this side toward the free wall, anterolateral and posterolateral. If you see the coronary sinus on echocardiography, that means you are looking at the posterior aspect of the annulus and the leaflets, and most likely close to the posterior septal commissure. On the right side, in image C, we can see the leaflet of the tricuspid valve and the transition between the left atrium and the left ventricle. Here we have the largest papillary muscle, so this is most likely the anterior leaflet. And if you touch the
هادي خلط له. remets ton micro. Ton micro est coupé. Dahou, docteur Dahou, remets ton micro. Ton micro a été coupé. C'est Abdellaziz. Ton micro, ton micro. On n'entend pas. Ton micro est coupé. Tu m'entends? Remets ton micro, ton micro. Ton micro a été coupé. Tu ne m'entends pas. C'est Dahou. Remets ton micro. Est-ce que tu m'entends? Ton micro est coupé. Active ton micro.
Il est activé, est-ce que vous nous entendez?
On l'entend. Quelqu'un t'a copié le micro, je ne sais pas qui c'est.
Ah non, non, moi je ne l'ai pas touché, ok, c'est bon.
Continue.
Non, il n'y a pas de problème. Il n'y a pas de problème. Donc, je reviens à la présentation.
Oui, non, on suivait jusqu'à sinus coronaire.
Donc, voilà, coronary sinus, this is the posterior aspect of the valve. If you see it on the echocardiography, that means you are posterior, and you are looking most likely to the posterior septal commissure. If you look, you see here one of the leaflets, most likely the anterior leaflet here, because we have the largest papillary muscle. There is no really tricuspid annulus stricture like the mitral side. The mitral side, you have mitral annulus that can hold any device. There is not such a thing on the right side. The right side is a smooth transition. You have the leaflet inserted directly on the myocardium. There is almost no tricuspid annulus. The surgeons know this, but sometimes this is a problem because when you implant an annular device, it can detach because there is no strong support to the device. One of the important structure when considering replacement tricuspid repair using annular devices is the right coronary artery. And you see that the right coronary is close to the tricuspid annulus, surrounding the annulus, but mostly in the mid portion and the distal portion of the annulus. It's quite distant on the proximal part, and it may cause sometimes coronary injury during the procedure when doing transcatheter annular device implantation. So this is very important to study before the procedure. We use CT scan and angiography to characterize the coronary and the distance between the two structures. There is other surrounding structures that is important to look at before doing any procedure. We have here in the anterior aspect of the valve, you have the conduction system. The AV node is close to the anterior septal commissure. Also avoid this part when you are doing device implantation, especially annular device. The coronary sinus here is toward the posterior septal commissure, as said before. And we have also the septum, membranous septum here, close to the AV node and close to the anterior septal commissure. We have here the anterior leaflet on the right side in the blue color and the septal leaflet here. So if you are too close to this, you may create septal defect at this level. So this is summarized anatomy, but this is a very schematic. You have the aorta on the anterior side. You have the tricuspid annulus with the three leaflets here. Posteriorly, you have the AV node close to the anterior septal commissure and the aorta. The dilatation of the tricuspid annulus occurs on the free wall, and you have the right coronary artery that becomes very close to the tricuspid annulus in mid portion and distal portion, and will it's very important to exclude close contact between the two structures before the repair with the annular devices. The pathophysiology of the tricuspid, we'll see it next, but here present main mechanisms of the functional tricuspid regurgitation. So following the dilatation of the right ventricle from any cause, that can cause dilatation of the tricuspid annulus, the tethering or the tenting of the leaflet, and then more the tethering happens, tricuspid regurgitation will progress, and this will cause more dilatation of the right ventricle. So this is on the right side, a surgical view, and here this scheme for the surgical view, you have the septum side on the bottom, the anterior leaflet here, and the posterior here. Most of the dilatation occurs toward the posterolateral aspect, and in 40% of cases we find also dilatation in the anterolateral aspect, and we can see this gap or defect in coaptation between the leaflet that causes the tricuspid regurgitation. It's very important to notice that the gap is not circular. Tricuspid regurgitation orifice is almost never circular, except in the early stage of the disease. It can be any shape but not circular, and this has an impact on the quantification of the tricuspid regurgitation. This is one of the studies that has looked at the mechanisms of the functional tricuspid regurgitation in 2012 by Topolsky and colleagues. They opposed here two different aspects of the functional or secondary TR. You have the case of, this is a normal right ventricle with no dilatation, and no dilatation of the tricuspid annulus. Here you have a case or a presentation of a just dilatation of the tricuspid annulus with mild moderate dilatation of the right ventricle, but the ventricle is still normal shape. It's quite triangular. And this entity is mostly due to the dilatation of the tricuspid annulus. You see the leaflet that is almost now tethering. They are flat. And on the right side is most likely patients with pulmonary hypertension from any cause that cause a dilatation of the right ventricle in the middle, most in the mid RV more than at the base. And these are the worst cases of the secondary tricuspid regurgitation. And it has been shown also there is an entity that becoming more recognized when you have a patient with no etiology found, but the patient has atrial fibrillation. When you have an atrial fibrillation, what happens is the dilatation of the tricuspid annulus, I would say isolated dilatation of the tricuspid annulus. And secondary, and later on we'll see dilatation of the right ventricle. And this entity is called atriogenic or idiopathic, but it more likely will become something related to the right atrium dilatation before right ventricular dilatation and the atrial fibrillation. So we can separate the classification of the secondary TR, as you can see here, very tethered lateral and septal leaflet with the restriction of the septal leaflet. We can class the mechanisms and etiologies according to the cause or according to the morphology of the tricuspid. If I look at the morphology, this is due to the tethering of the leaflet. And we can see here tethering of the leaflet or displacement of the papillary muscles, RV dysfunction, annular dilatation. If we look at the cause, we can say secondary tricuspid regurgitation due to the left-sided heart diseases, due to the RV dysfunction, to pulmonary hypertension, and so on. And the most cause of the tricuspid regurgitation is in 85% error, if not more, is secondary. So primary TR can happen, but it's rare. It's rather rare. You have here congenital abnormalities, but we don't see them in old patients like the patient we treat nowadays. And I want to just point the acquired causes. One of the most common in primary TR is myxomatous degeneration or Barlow disease. with a prolapse and also flail, that means eversion of the leaflet. You have endocarditis in some category of patients with IV drug intoxication or immune depressed patients. You have rheumatic disease, probably the case in some countries, but not all the countries. And you have the pacemaker or device related. And this is becoming more frequent since we are implanting pacemakers with leads and defibrillator. Here, an example of a primary TR due to degenerative tricuspid regurgitation. This is a prolapse, and we see the flail, actually, the edge or the tip of the leaflet is going toward the right atrium, causing tricuspid regurgitation. On the right side, you have a prolapse of the septal leaflet, causing significant tricuspid regurgitation. Here we have a case with the pacemaker lead impingement, that is interaction between the leaflet and the lead. Actually, the lead is attached to the leaflet. There is adherence, there is connection, and the lead is moving with the leaflet. This is one of the signs. When you look at the interaction, you see if the lead is moving with the leaflet, this is a good sign that there is probably impingement. And you have on the right side pacemaker lead within the jet area, and it's moving with the lead also with the leaflet. So this is this kind of patient cannot be treated with transcatheter devices unless you remove the lead. Another case here with the interaction between the septal leaflet and the lead, excluded from other trials because of that. And we can appreciate this interaction with the 3D. We see the septal leaflet here, the lead completely attached to the lead, the leaflet attached to the lead and moving together, and a coaptation defect here in the center. There is a big gap. How to image tricuspid valve? Of course, we have transcatheter and transthoracic, and we have 2D and we have 3D images. For transcatheter devices, the TEE, the transesophageal echo, will be the main modality. But for the diagnostic, the initial modality remains always the TTE. So we start with the TTE, we look at the valve, and we found something that needs to be investigated more and more. We go to the TEE. So in the recommendation, it's a class 1 to start with the transthoracic echocardiography, and then if you think there is something you can do to the tricuspid, you go farther with other modalities. I want to show this image. This is a reconstruction from the 3D to show you the shape of the tricuspid regurgitant jet. As said before, it's almost never circular. This is a funny shape, or could be banana shape, any shape, crescent shape, but not circular. This has a big impact on the imaging and quantification of the tricuspid regurgitation. If you look at this, at the width of the jet here from the anterior to the posterior, it's a big gap. If you look from here, it's small. So if you image your valve from this side, from septal to lateral, you will see only small jet. If you image the jet from anterior to posterior, we'll see a big or large jet. So you can underestimate or overestimate the tricuspid if you look at the valve from one side. For this reason, it's very important to look at the tricuspid from different sides. The minimum is 2 orthogonal plane, but there is no maximum for the valve imaging for tricuspid valve. You can provide as much as you can imaging. It's always useful. We start usually from with this view. This is the RV inflow view, showing the anterior and the septal or posterior leaflet, depending what you see on the posterior aspect here. And you can put the color and see the tricuspid jet, TR jet, and do all the quantification with PISA or other modalities. You can acquire your 3D from here, and you can also characterize the valve morphology and the right ventricle morphology and function from here. This is the anterior wall of the right ventricle. You can see if there is abnormalities of the valve. and you can measure tricuspid annulus in this dimension. So from this view, if you see, this is the anterior leaflet, and if you see a part of the coronary sinus here, that means you are looking at the septal leaflet. And you see here, this is the anterior ventricular septum, and small part of the left ventricle. So this is the septal leaflet. On the right side, if you don't see the coronary sinus and no left ventricle, that means you are looking at the anterior aspect and the posterior aspect, both anterior and posterior walls of the right ventricle and anterior and posterior leaflets. And you can tell where the jet is located, and if there is prolapse, where the prolapse is located. From the four-chamber view, this is a basic view. We cannot not provide four-chamber view for TR quantification or TV examination of tricuspid valve. You see the septal leaflet close to the septum, and of course the lateral aspect here could be the anterior or the posterior leaflet, depending on other structure, if you see them or not on the echocardiography. So if you see here, you see in the bottom, if you see on the left, image C, if you see part of the aortic valve or aortic root here, this is most likely the septal and anterior leaflet, because the aorta is anteriorly positioned. If you see the coronary sinus on the right side here, most likely you are looking at the septal and the posterior leaflet here. And you can find more information about the imaging of tricuspid valve with the TTE on this reference here published in 2016. Another view that can allow you to see the three leaflets at the same time. If you have more three leaflets, you can see them. This is the in-face view of the tricuspid valve. From the short axis, you can angulate your probe toward the tip of the valve, and you can see here the septal leaflet, the anterior leaflet, the posterior leaflet. You can acquire a 3D image. It's a nice image here. Septal leaflet, posterior leaflet, and most likely an anterior leaflet with two scallops. It's a big scallop here and second scallop here. It's like separated. It's separate two scallops on the right on the anterior leaflet. An example here with the 3D image acquisition from Transgastric showing interaction between a lead and the leaflet. The lead is located here in the posterior septal commissure. This is the anterior leaflet, the septal and posterior. You can put your color. This is a case of TR caused by the interaction between the lead and the leaflet, and cannot be treated with transcatheter devices or surgery unless the lead is extracted. The next section, I don't know if you want to stop to make a pause here and ask some question, or continue with the TEE, and then we ask questions.
Continue with TEE, and after that we will ask some questions.
Okay, good.
Put the question on the chat, please. If you have questions, write on the chat. Thank you.
So the most exciting part, I think, here, both for this topic and this presentation, is the next part, is the TEE and the transcatheter devices. So we have these recommendation on how to perform a comprehensive transesophageal echocardiography. There is 28 mandatory views, but I'm not going to go through all these views. I just want to show you the most important views to use for patient selection and for procedure guidance for performing transcatheter devices. This is not intended to be comprehensive. This is intended to be focused. We will need to look at the tricuspid valve from at least two different levels. The mid-esophageal level here, mid-esophagus, and the transgastric views. So we need to look at them the valve from the mid-esophageal level and transgastric level, and this information is complementary And if you don't have these views, you cannot guide your procedure. This is very important. You notice that the right ventricle is toward the right side, so the tricuspid valve is toward the right side. So when you image the tricuspid valve, if you don't see the valve very well, just do clockwise rotation to push your probe toward the right side. If you don't see it, you can also use the flex to the right and to the left. Flex to the right will show you that we expose the tricuspid valve to you. And sometimes you need to do some angulation toward the anterior aspect to see the valve very well. So these are basic manipulation of the probe to see the tricuspid valve. First and basic view to start with is the 4-chamber view that we can get at 0 degree from the mid-esophageal level. This is to start with, but it's not the main view for all the procedures, guidance, and this patient selection. You can see from this view the septal leaflet here, and either the anterior and posterior leaflet, depending on how deep you are. If you are upper level, this could be anterior or posterior. You can put the color and see if there is interaction of any lead between the lead and the leaflet if you have lead. You can also do a quantification of the tricuspid, measure the tricuspid annular dimensions, severity of the tethering, RV function if you can, and you can quantify tricuspid regurgitation, of course. If you have a shadowing if you are at the upper level and you have a shadowing of any structure, because you are in the mid-level, you have the aortic valve. So in that case, you can go deeper in the esophagus. So you can go deep esophageal view here. You eliminate the left ventricle. This is very important. You push your probe until you don't see the left ventricle. If you see only the right ventricle, so most likely this is the septal leaflet and this is the posterior leaflet, and you can appreciate here the tethering or the restriction of the septal leaflet and the cords that are limiting the movement of the septal leaflet. This is one of the difficult cases to perform with the transcatheter devices because of this. And you can also put the color and characterize the regurgitation as well. Second view, and this is one of the key views. This view and the next view are the two most important views we use for structural procedures, before the procedure and during the procedure and also after the procedure. This is a key view. This is a mid-esophageal view at 50-70 degrees. You see the aortic valve. You have to see the aortic valve here and two leaflets, the anterior and posterior leaflet of the tricuspid valve. The septal leaflet is in the third plane, so you cannot see it unless you cut and you expose the second plane, the orthogonal plane, which we see X-plane on echo machine. So this is very important view, and we'll spend more time on this view. So you have here the aortic valve. Then you have the anterior aspect of the tricuspid valve, and you have posterior aspect of the tricuspid valve. This view, as said, can be obtained from between 50 and 70 degrees, most of the time close to 70 degrees. You can do a clockwise rotation, so to push your probe to the right side, or right flex of the probe. And you can use the biplane mode, the X-plane. So your line here is the second plane. So if you cut the valve at any level here, you will expose the second plane on the right side. So instead of doing imaging, image by image, you can from one image acquire the view you are looking at and the second view in the orthogonal plane. So this is very helpful. This is time efficient and provide crucial information. So this view on the right side, we call this the grasping view. So if you are using edge-to-edge repair device like the MitraClip, this is a mandatory view to get, because this will guide the progression of your catheter and device across the valve and the capture of the leaflet. This is very important. So this is, if you go toward the anterior aspect, toward the aortic valve, you will expose the septal and anterior leaflet. If you go posteriorly, you will expose the septal and the posterior leaflet. But this is one of the key view to remember. This is very important. Another example here, and we are cutting toward close to the aorta. So this is anterior and septal leaflet here, and we can see a lead moving, and we can see that there is a jet, the lead located in the jet area, part of it in the jet area, part of it not. That can be a problem for the repair. The second key view, and this is, I would say, the most important from all the views. This is transgastric short axis view of the tricuspid valve, and we call it the in-face view. The valve is looking at you. We are looking at the valve from the right ventricle perspective here. So this is the septal leaflet on the right side. The anterior leaflet is close to the aortic valve, and the posterior leaflet is to the other side. We can appreciate here many things. The anatomy of the tricuspid valve, number of leaflets, the size of the coaptation defect or the gap, the distribution and the density of the cords. If there is a pacemaker, the location of the pacemaker, and if there is interaction with the leaflet. You can see the jet location and the extent across the anterior, across the commissures. And this view is the most used, I would say, for patient selection and also procedure guidance. Because here you can see where you can decide how to plan your procedure, where you intend to put the device, and etc. How many devices you intend to put. So, as said, this is a key view. You see here an example of patient with a pacemaker lead located just at the center of the coaptation defect, and this case cannot be implanted with treated with MitraClip, for example, because you have a lead here. You can first, it's difficult to implant the device because of the lead, and you can damage the lead. And the patient like this one are usually excluded from the trial unless the lead is extracted. We can use the 3D modality to get a full volume of the tricuspid regurgitation. And one of the views we use is the mid-esophageal view, 60-70 degrees. You can take part of the aorta to give the person who is looking at the images the ability to recognize the anterior aspect, and you include all the structure. You don't cut at the level of the annulus. Include more structure, so you can, when you do reconstruction, you get the entire tricuspid annulus and tricuspid valve, and you can even see a very small structure here, like this is the anterior vena cava. You have Eustachian valve here, which can be a problem when you access the inferior vena cava toward the tricuspid valve. If it's a big Eustachian valve, it could be an obstacle for progression and rotation of the device, the catheter and the device. You can appreciate the coronary sinus here. This is the tricuspid, one of the leaflets. An example of 3D with the reconstruction here. This is actually the 3D live, but you can do similarly reconstruction. You have from one plane, you can get the different planes. You have septal, anterior, and posterior leaflet, and you can characterize the anatomy almost like what pathophysiologists from macroscopic perspective. And this is very important in the era of transcatheter devices. You have here a 3D example with the lead sitting in the posterior septal commissure. Septal leaflet is here, the anterior is here, and the posterior toward this side. The aorta is aortic valve is here, so we know this is the anterior aspect. The mitral valve is in the other side. There is, you can say 100%, almost 100%, that there is no interaction between the lead and the leaflet, and despite the presence of pacemaker lead, you can repair this valve with any edge-to-edge leaflet, edge-to-edge device. It could be right clip, mitral clip, or any other. And also we can perform annular device repair in this case, despite the presence of pacemaker. Another example of reconstruction here with the 3 leaflets. So 3D is very helpful. You can measure many things. You can get a lot of information, measure the gap size, the leaflet size, and you can measure the length of the leaflet, because this is important also for edge-to-edge repair devices. This example for a lead here, for example, you have a lead. We don't know if there is interaction, reconstruction from the 3D, and we see that the lead is the anterior septal commissure, and there is no interaction with the leaflet. Most of the gap is toward the center. So this is most likely can be repaired with a device implanted toward the center of the valve. One of the most important measurement before to do edge-to-edge repair is the gap size, with the defect size from the septal to the lateral side. And if you have a large gap, like more than 10 millimeters, this is almost a predictor of failure for the procedure. If you have a small gap, less than 7, this is more appropriate for the repair. And if you have in between, this is considered between 7 and 10, is a borderline case, need to be discussed according to the other features of the valve anatomy and other parameters as well. It is of course important to talk a little bit about the quantification of tricuspid regurgitation, but it will not be extensive, as this is not intended for how to quantify the regurgitation. This is a secondary topic. But I wanted to show that the first thing to look at when doing your quantification is the tricuspid valve morphology. You can look at the valve before to put any color. If you see severe lesion of the valve, you have severe prolapse with flame, you have the leaflet completed on the right atrium, ruptured papillary muscle, you have severe retraction, large gap, you can be sure before to put the color that this is severe regurgitation. Then if you don't have this information, of course, you can measure a lot of do a lot of measurements. Some of them are semi-quantitative, some of them are quantitative, but it's important to do quantification. So the semi-quantitative parameter we use the most is the vena contracta, the narrowest width of the jet. At the origin of the jet need to be measured at the level of the tricuspid leaflet, not too much in the right atrium. If you have something around 7 millimeter or more, this is consistent with severe tricuspid regurgitation. Another semi-quantitative parameter is to look at the reversal flow in the hepatic veins. So you put your PW in the hepatic veins, and if you see a flow reversal there, this is significant tricuspid regurgitation. The quantification is mostly done by PISA method. And according to the guidelines, severe regurgitation is defined by regurgitant orifice more than 14 millimeters square or 0.4 square centimeters, and regurgitant volume higher or equal to 45. But we use other modalities, especially in the setting of the research studies. We use other modalities. We use 3D color to measure the jet area at the origin or at the 3D vena contracta area, and we use the quantitative Doppler method. So for the PISA, PISA is basic, like a basic measurement, but we need to adjust the measurement to get a decent quantification. Your aliasing velocity here need to be around 28, let's say 25 to 35 centimeter per second. Then it can be adjusted according to the velocity of the tricuspid regurgitation. If you have low velocity here, like 200 centimeter per second, 2 meter per second, you can adjust your aliasing velocity to around 20 centimeter per second. It's around 10%. The velocity, the aliasing velocity is around 10% from the TR velocity. If you have, for instance, 300, you can put 30 centimeters per second, and so on. And this is very important because you need to well define the PISA region, the shell, to get the most accurate PISA measurement. For the 3D, I will show you an example. And for this second parameter, which is the quantitative Doppler, it's quite challenging, but when it's well done, it's good. It's worth it to do it. You can measure your cardiac output at the level of tricuspid leaflet, and the same from the tricuspid annular dimension and the VTI in the tricuspid annulus level, and then you get the volume. Then you subtract this volume minus aortic or pulmonic volume, and you get the regurgitant volume. Because in a patient without significant aortic or pulmonic regurgitation, the cardiac output is similar in the tricuspid, in a normal patient, of course, the tricuspid, aortic, and pulmonic. So if you have higher cardiac output in the tricuspid valve, that means because of your regurgitation. So by subtracting the volume of the crossing the valve minus the volume in the pulmonic of the aortic valve, you get the difference of the volumes and you get the regurgitant volume. So here an example of the quantification of tricuspid regurgitation by 3D method from acquired from 4-chamber view TTE, transthoracic. So look again here that the shape is not circular. You have a larger vena contracta in 4-chamber view compared to 2-chamber view. If you do your tracing, you get the airway here, 1.4 to 1.6 square centimeter. You have here on the right, this is from 4-chamber view, 2-chamber view, and this is the shape and the quantification of the area, and you get 1.4 to 1.9. Sometimes you need to average many, say 3 to 5 cycles. And especially if you have atrial fibrillation. We tested the different parameters in some of our studies, and we found that the quantitative Doppler is sometimes better than PISA. We actually found that PISA can underestimate the severity of tricuspid regurgitation in nearly 30% of cases. Whereas we found the average of the two vena contractas. What we did is the average the vena contracta from this view and this view. If we, let's say this is 10 and this is 5, the addition is 15, the average is 7.5 or 8, and this had much better correlation with the 3D than the PISA. So 2 simple measurements from the vena contracta, no quantification. If you average them and you compare to the 3D, there is a better correlation than PISA. PISA sometimes in almost 1/3 of cases underestimates the tricuspid regurgitation for many reasons. I cannot expose them, all of them in this presentation. I showed you a case of a patient with a large gap. So these are patients non-treated for a long time, and the regurgitation is very severe, is a huge regurgitation. So some people propose the new classification of the tricuspid regurgitation. The severe range, instead of saying severe, they divided the severe on 3 categories. So severe, massive, and torrential. And you have here the cutoffs from this view published a couple of years ago. I didn't put here the year. I believe this was in 2017, because sometimes you treat patient with very severe TR, and there is a decrease in severity, and when you measure, you can find still quantification consistent with severe, like 0.4 square centimeter. If you start from 80.8 or 1 square centimeter and you get to 4 square centimeter, this is 0.4 square centimeters. This is 60% reduction. But you cannot see it if you say all severe. So this is why this classification was proposed, to take into account the reduction within the severe range. And this is mostly for research purposes, but is getting used much more for clinical practice as well. So it has some criticism, but it has been shown to be useful to predict the outcome. I think we can stop here. This is the next part of the treatment and all the devices. If you have any question, you are very welcome. And can be in any language.
Okay, thank you. Thank you very much for this excellent presentation. And we have one question about Dr. German, Dalia German. Ask your question. Active ton micro. German, are you here?
I'm here. I have a bad connection. Thank you, sir, for your presentation. What are the other predictors of to assess the result of the age-to-age repair? Do we take into account the height of coaptation as for mitral valve, and or only the gap, the area of the gap, dimension of the gap?
Yeah, thank you. Excellent question. This is one of the main question when we before to repair the tricuspid. Actually, they studied both. There is a couple of studies, most of them retrospective or prospective, but small studies. There is no large studies, prospective, randomized, that measure these parameters at the base. But from the retrospective or prospective small studies, we found that the height of the coaptation, that means the tenting or the tethering, higher than 10 millimeters. When you have more than 1 centimeter, you have almost a vertical valve leaflet. This is one of the predictors of failure. And regardless the type of the device, could be an annular device, could be edge-to-edge device. If you have very tethered and restricted leaflet, more than 10 millimeters, this is one of the predictors. The second predictor is the gap size. And the gap size, I showed you an example of the gap size in the septolateral direction. If you have a gap more than 10 millimeter in the septolateral direction, this is another predictor of failure. So you can keep in mind for now these two measurements, 10 and 10. So 10 for the tethering and 10 for the gap size. But you have to know also that the devices are evolving. In the beginning, it was difficult to catch a gap, to close a gap of 5 or 7. Now the devices are getting larger, so these quadrants may change in the future. But yeah, this is two most important parameters. Of course, there is other things. If you want to do edge-to-edge repair, you have to look at the structure, at the chordae structure. Les cordages, very important. Yes. Because there is about 20 to 25 chords in a tricuspid valve, and there is no difference between male and female. There is a pathological study that have shown similar number of chords in men and women, in approximately 20 to 25 chords. If you have the chords more dense in one of the leaflets, that means it will be challenging, it will be very difficult to catch the leaflet during the procedure, especially with some devices. So you need to look at the valve and see if you have a jet in the anterior septal commissure and you want to grasp the septal and anterior leaflet. Maybe I can go back and show this view here. Do you see the image?
Yeah.
Yeah. So, for instance,
yes.
This case has a large TR jet going from the posterior commissure almost to the anterior commissure. So this tells you that you will need more than one device to fix the valve. You will need probably 2 devices, or in some cases more. The second thing, look at the gap here. From the septolateral direction, it's quite a large gap, around probably 10 millimeters. This is going to be challenging, but if you want to implant the device in the commissure, this is doable case. We can do it. There is also, you need to look at the pacemaker, if there is a pacemaker, and the location. If you have a pacemaker, and this is one of the thing we'll talk about in the tricuspid studies, this is one of the predictor of failure, but there is no strong data to support that. You can do a repair with a successful result if you have a pacemaker like this one. You need to look at the chords. You see here the small white lines here. These are the chords. les cordages, if they are dense in the region of the grasping where you intend to put the device, you can be sure that you will be facing a big challenge during the procedure. Sometimes your device cannot go into the leaflet, and sometimes it can be hold between cords and distort your trajectory or the delivery, and you can inhibit the delivery of the device. We heard many stories about this. Not always easy. So patient selection is a key, and the imaging is one of the main important things before the repair. We need to look at the valve many times before to consider a repair, so you can be sure that this is something doable and somehow easily. Another question? I hope this answers.
About Amal Amrouche, our echocardiographist, the young echocardiographist. هيا لا أمل يلا.
I have a question about functional tricuspid regurgitation. The indications for surgery. For now, it's by the annulus diameter, but with evolution of quantification methods, especially the vena contracta area, these indications for surgery will change or not?
No, I think the regurgitant area by the 3D, it's an indication of the severity of the regurgitation, but it's not for surgery. The surgery will depend on many other factors. Will depend on clinical factors. Will depend on the size of the annulus, because the main approach to repair the tricuspid valve surgically is either an annuloplasty or replacement. And these parameters, they don't look. They looked at the tethering. There is many studies that look at the tethering. That same question asked before. Severity of the tethering and the recurrence of tricuspid regurgitation after surgical treatment. If you have severe tethering, but in the surgical studies, the tethering cutoff was around 8 millimeters. So if you have tethered valves, whatever your method for the repair, surgical repair, you most likely you will have recurrence of tricuspid regurgitation after surgery. But for sure there is no indication to use the 3D for surgery. The surgeon will go and one of the indication you will see next portion, you will see why the surgeons will not use the imaging for their strategy.
Okay, thank you.
Abdullah, Saeed, ask your question, Saeed. Saeed, you have a question? Abdullah.
About the assessment of tricuspid annulus, is the 4-chamber view is still the best view, or there is multiple views, or multiple views are necessary, like subcostal view? It is better, maybe it's better than the chamber view, the 4-chamber view.
Yeah, this is a very good question. The 4-chamber view, and I think I will have to show you. I will answer you, but I will have to show you some nice images just to make it easy. But the 4-chamber view is the main view for the measurement of the tricuspid annulus in the septolateral direction. This tricuspid annulus is D-shaped, is oval, it's not circular. So if you measure one diameter, it's not going to give you a clear idea about the annulus size. So there is the standard RV 4-chamber view, but also there is focused RV views. The focused RV views are very important. If I can find this here, I can show it to you. I hope I can show you these images in another presentation, but it's very important to show this. Do you see the image now?
No, black screen. No image.
Okay.
We don't see. You have to share.
Yeah, it says here it's sharing. I will stop share and share again.
Oh no, okay.
So probably it will make it working. Nothing.
No, you are
okay.
Screen.
No problem. I will go back to the other presentation. But just just I will answer you like that. No problem. For maybe we can consider presenting this another time.
Present now. To present now.
Okay.
You have to click on the. Professor Sufi.
I just will answer the question to the person. To this question, complete the answer to this question. So there is no only single view for the measurement. The subcostal view is not the best one. We need to consider a focused RV view. This is the standard according to the recommendation of the American Society of Echo. 4-chamber view focused on the right ventricle. This is the best method for the measurement of the septal direction of the tricuspid annulus. And also because it's kind of a landmark. When you measure one time on the same view, you have better reproducibility for your result. If you one time measure on focused, another time when you see the patient, you measure in a different view, like subcostal, inflow, or a standard 4-chamber, you will have variability in your measurements. So use focused RV, and we use the 3D. The parameters now we use more and more 3D, both 3D echo and CT scan. So one single parameter, one single measurement of the annulus is not going to be helpful for you.
Okay. Professor Taleb Sufi from Tlemcen has a question. Professor Taleb.
Thank you. I have a question about the taps. Does the taps
it is good or not?
Sorry.
Assessment, yes. Right ventricle.
Yes. Does the taps retain its place in the assessment of right ventricular function if we have a several tricuspid regurgitation?
You mean if you have several jets, if we use TAPSI?
Yes.
Yeah.
We retain the taps in the evaluation of right ventricular function?
Yes. The TAPSI is a measurement of the displacement of the right ventricle. Let me show you something. From the same, do you see, probably. Pour le TAPSI, c'est très important. Le TAPSI va quantifier le déplacement. TAPSI will quantify your displacement in the longitudinal direction. If you cut your ventricle on this side, it will quantify one of the parameters of the RV function, one of the dimensions. But also there is, contraction in the other side. So there is a multiple parameter. We can use TAPSI regardless the number of jets, but in some cases you cannot use the TAPSI accurately because many things. If you have a device, if you have an annular device implanted in the tricuspid annulus, that will hold your annulus from going back and forth, and then you will underestimate your RV function. But if you have a native valve, you can use your TAPSI regardless of the number of the jets. We use other parameters. We use the fractional area change, but in the setting of the tricuspid regurgitation, fractional area change will overestimate the function. And we use also the strain. I don't know if you are familiar with the
strain. Yes.
Yeah, we use the strain a lot, sometimes before the studies. That gives you a better idea about the global contractility of the ventricle. And it's better than TAPSI. We showed a couple of years ago that TAPSI predicts mortality, regardless the strain predicts mortality regardless of the severity of tricuspid regurgitation. And also there is one group of here in the US that presented with the strain, both predicted mortality. So, but the strain.
So,
yeah.
when we have a severe tricuspid regurgitation, the TAPS became c'est-à-dire, il faut qu'il soit remplacé par autre chose, par un autre paramètre, c'est ça?
Non, il peut être utilisé, il n'y a pas de problème. On sait très bien lorsqu'on ferme la régurgitation tricuspide que parfois la fonction BD va baisser. Comme le TAPC ou le fractional area change, le pourcentage de changement des volumes, ça peut changer après la fermeture. Mais ça veut dire qu'ils étaient un peu surestimés avant. Et ça, c'est le cas de patients avec une insuffisance très sévère, très avancée. Lorsqu'il y a une régurgitation modérée, juste modérée sévère, ça reste quand même très valable. Il y a une étude qui a été publiée récemment avec le Partner 3 Study. C'est le paramètre qui était un des paramètres qui était prédicteur de mortalité dans une large cohorte d'environ de 1000 patients, c'est le TAPC. Le TAPC n'a pas été mesuré comme on le mesure en 2D, en M-mode. Ça a été mesuré en DD, ça veut dire en 2D. Ça veut dire vous regardez à l'aval, vous stoppez votre mouvement de l'anotricuspide, vous mesurez la distance de l'anotricuspide jusqu'à l'apex, et vous laissez parcourir, vous stoppez en fin de systole et vous mesurez la distance de ce point jusqu'à l'apex et vous faites la différence. Ça, c'est to the measurement of the TAPC. Ça, c'est une nouvelle méthode. La première publication écrite comme ça, large cohort, c'est Partner 3. Nous avons participé dans cette étude avec le groupe du Canada où je travaillais avant. C'est l'un des prédicteurs de mortalité. Donc, ça va peut-être shifter parce que le M-mode, lorsque vous mettez votre ligne M-mode et le cœur bouge beaucoup, c'est que vous pouvez un peu surestimer ou sous-estimer. Beaucoup de fois, on surestime parce qu'il y a les courbages, il y a le mouvement latéral et tout. Donc, c'est ça.
D'accord, merci. Thank you.
Bienvenue.
Bon, je